I'm Sheryl Catz. I'm on the faculty at the UC Davis Betty Irene School of Nursing. I'm a psychologist by training, and I came to this conference last year as a bit of a spectator just to see what was going on, and I noticed something interesting as a theme that I took away from the meeting last year, and that was that there was this surprising mismatch between patients' and providers' interests and abilities to share and to meaningfully use information that was collected through mHealth technology. And the reason I was surprised is because at a conference like this, the people that show up, I figured, would be sort of a bias sample of people who were able to do this and felt maybe a little more satisfied. Now, the flip side of that is, I work with a cardiology group at UC Davis where the physicians want their elderly, pretty sick heart failure patients to use telemonitoring devices, and the patients are not so sure about that. So, it spans both spectrums, but I think it's worth pointing out that even in a group like this, there is this kind of mismatch between patients' and physicians' ability to use things together. And so what got me thinking about it was this idea that we'd been kicking around at our group. I collaborated a good bit with folks at Group Health Research Institute, where I previously worked, and we were thinking about how do you make things patient-centered? If the patients want to use and connect their data that's collected from a mobile health device with their care. And so, we talk about this disconnect, and you've heard it again this year, I think, in many of the sessions. And the thought that we had is that not only does it need to be patient-centered, but it needs to be provider-friendly, and not just physician-friendly, but like provider team-friendly in order to actually meet that patient need to communicate more effectively with the folks who are providing their care. So I'm not advocating that we be physician-centric, just to be clear. I'm advocating here that we need to take the whole group, the whole constellation of people who are potential users of mHealth data into account at the design stage. So this is kind of my visualization of what Ida was, I think, describing in her talk. On the left, you see, I think this is what the data kind of feels like to a provider who's being barraged with a bunch of, maybe it's Fitbit data or maybe something from a self-tracker about your meds or what have you. It's like this big mash of stuff, and what do I do with it? And what we need is to make sense of the shared mobile health data shared between patients and provider teams, and to try and figure out who needs which pieces and how do we organize it, and who on the team's the right person to get it. Maybe it's not the physician at all. Maybe it's the pharmacist who needs a particular piece of information and wants to use that piece of information. And so that's kind of the premise that I'm talking about today. So, just for a little background, my colleague Jennifer McClures has a grant funded by NIDA that I've been working on with her to develop a mobile website that kind of looks like an app, but it goes across whatever platform patients have. So we've designed it as a mobile website where we're trying to help people who are quitting smoking to stick with Chantix or varenicline, which is a stop smoking medication, for the 12 weeks that we know will help them be twice as likely to be quit 6 months from now if they can use that kind of medication for the first 12 weeks that they are quitting smoking. And so we've been working to support adherence by looking at the kind of symptoms and side effects from the medication and from nicotine withdrawal symptoms that people experience that tend to make them quit using the medication. And so we've got sort of adherence support plus a smoking cessation kind of self-help content in our mobile website. And it's designed when there's something more serious to flag the physician or the nurse or the quick coach, whoever they're working with, on their clinical team, but only when it's something that's really something that should be actionable. And otherwise, it gives them real-time information and tips about symptoms and motivational things that they're experiencing that they can have right there in their pocket when it's needed. Because people never call and tell their doc that, oh, I'm having trouble quitting smoking, or, I'm uncomfortable with nicotine withdrawal. What do I do? But you might do that looking it up on your app. So we both reach out to people, and they can come to the app whenever they want to get this information. So in the process of getting this funded, and this is just kind of an example of when people get their tips back, they click on the ones that they've already endorsed, and then they get a little kind of bullet list for each of the things that is a current problem for them. But in the process of developing this, we're just about to launch the pilot trial now. We've spent like a year of development, and we're going to follow that up with a survey of potential future users. And by that, it's not the patients, because we're doing the patients first. We're going to look at all the quick coaches and the nurses and the physicians who might be potential users if we rolled this out, and show them what the dashboard for the providers looks like that the study team's using, and get their input about how that would or wouldn't be useful to them in practice with this type of problem. And this piece that was prompted by questions from reviewers who I think were physicians, who said, gee, I don't know if physicians would be willing to do that or get alerts if someone has, a cardiac issue while they're taking this med. They might not want that. And so that got us thinking, Jennifer McClures and I, who's the PI of this study, it got the two of us thinking about what, in a really broad sense, when we look at things like treatment adherence for other chronic conditions, whether this is going to be a really broad-based issue. And I think from the things that I've heard at this conference this year, I would say yes, that seems to be a pretty broad concern, that providers really need to, in order to work collaboratively with patients around something like medication adherence. So not physical activity data that maybe they don't care about, but something about, I've prescribed you a medication, are you taking it, and do I need to titrate the dose based on what you're telling me? So something that they might care about, that really needs to happen in a different way. Adherence is something that cuts across a lot of chronic conditions as well as acute situations like the smoking cessation. And inconsistent medication use is a really common problem, as I think any of us who've ever been prescribed a medication long-term could attest to. So I really feel like we need a patient-provider partnership that enables patients to make good choices and to sustain the health behaviors that they want to, for example, consistent medication use, but also many other self-management behaviors. And so I look at, you may be familiar with the chronic care model that Ed Wagner at Group Health has rolled out kind of nationally and internationally. And this is a way of matching up a prepared, proactive care team with an informed and activated patient. And the piece that gets left out sometimes is how exactly do you, what's the collaborative piece that makes that happen? So, I've laid out, as applied to adherence here, kind of four core collaborative care elements, and it has to do with patients and providers collaboratively defining problems, patients and providers focusing on a specific problem, setting realistic objectives, developing patient-centered action plans that take into account the patient preferences and readinesses, creating a continuum of self-management training and support services, and providing proactive and sustained follow-up to monitor health status and to identify potential problems and to check and reinforce progress in implementing the care plan. So that's a mouthful, and I'm trying to get through this piece quickly because it just sets the stage for what I'm going to talk about. But I think it's important to be informed both by models of care and behavioral principles when we try and do something like have physicians and their teams and patients work together collaboratively to do something like get patients to be able to take their medications consistently if they want to. So the last time I checked, a one-way street seemed to be about half as useful as a two-way street, maybe even a little bit less depending on what direction you want to go. So, you know, the title of this talk is about two-way streets. And I want to end this kind of one-way street where you've got these commercial apps that are consumer-facing and they just don't connect anywhere. Just that's a one-way street. So, you know, people are really using these a lot, and certainly at this conference, we're probably the best examples of that. But not really enough of them, not enough of these self-management tools are integrated into care. And you've heard, I think, at this session and some earlier ones as well, about some of the reasons why they aren't. So how can mHealth tools become a two-way street between patients and their care teams? Well, for these tools to reach their full potential to support patient self-management and to support engagement in care, they need to do a couple things. They need to provide effective and acceptable communication between the patients and their care teams, and they need to be designed from the get-go to be responsive to the needs and the preferences of both patients and their multidisciplinary care team members. They also need to support collaborative workflows and to work seamlessly with clinical information systems. So when you have a two-way street in your title, it opens up all sorts of opportunities. So to get to this two-way street, we need to change our priorities ahead. So our next steps are integrating mobile health medication management tools into primary care practice through engaging patients and their primary care teams and using communication that's mediated by technology in order to monitor medication use. So there's an often overlooked user-centered design question, and that has to do with the team and not just the patient and not just the physician. So what we need to do first is to understand and articulate what are the design specifications that not just patients need, but the nurse, the care manager, the physician assistant, the physician, the pharmacist. What do they need in order to make this data useful and actionable for them to provide the best care for the patient? So what our team's goal is essentially to look at the patient, the multidisciplinary care team, the data workflow, and the clinical workflow to see how this can be accomplished. So laying the foundation for our two-way street. You know, first, to have this kind of bidirectional and effective communication with patients who might be using mHealth tools, the tool development needs to be based on an understanding of clinical information needs and the healthcare decision-making processes. So it can't be in isolation, separate from what's needed to make good medical decisions or good health decisions on the part of the patient. So what I'm going to talk the rest of the time about are kind of 4 different steps that that are an example of how our team kind of approaches this issue from a user-centered design perspective. So the first one is describing patient preferences for the design and use of shared patient-provider team technology. And we want to do this in order to support adherence to long-term meds for things like antihypertensives and lipid-lowering medications and meds for diabetes, and whatever else patients might bring to the table in a complicated medical situation. But those, for example, and we want to get a better understanding of who on the team and what data and when would patients want this kind of data shared. And so, that's step one, mostly the usual patient-centered approach that I think you've all been advocating for at this meeting. And then step two, we want to describe sort of role specific. So, are you the nurse on the team, the physician on the team, the pharmacist on the team? And disease specific, is the patient that you're working with someone who's got diabetes and hypertension, or just hypertension by itself? And we want to describe the sort of the functionality needs of different kinds of care team members that are related to medication adherence to these different kinds of medications for people with different chronic conditions, or maybe multiple chronic conditions. And so the idea here is to use things like user personas of a sort of a prototypical pharmacist, and to collect data from, say 10 pharmacists in different kinds of settings about what the prototypical pharmacist would want to use. Going back to that image of the puzzle pieces, which of those bags of sorted puzzle pieces do the pharmacists need, for example? And we would do this with each kind of team member. And have scenarios of use for each different kind of chronic condition, or a combination of several. So a scenario of use is sort of a narrative, usually like a one-pager, that kind of goes through things like, what if the patient were new to the medication versus if they've been on it for a long time? And what if they were on a particular kind of regimen, or that was complex, or one that was simple? What would those different scenarios be like? And so using those kind of user-centered design techniques, we think the next step then is to come up with a list of design principles and user requirements that outline the specific needs of care team members who would be interacting with this mHealth medication-related data. And so you can do things like have low fidelity prototypes, paper prototypes, and storyboards with, drawing pictures to show both patients and all the constellation of multidisciplinary team members what the possibilities are for dashboards the provider sees and interfaces that the patient sees, so that we can get feedback before things are developed on how patients and their provider teams might be able to use this data together in the future. So designing that at the beginning, not developing something and then after the fact trying to fit it in to, fitting in this square peg into a round hole of an EHR. We don't want to do it after the fact. What I'm advocating for is that we think about these kinds of design issues at the beginning, and to really be, I think the fourth leg of this stool is really looking at data workflows as well as clinical workflows, and making things that are going to complement or improve existing clinical processes and technology, rather than be at odds with it. So my take-home message here is that in order to pave the way to the two-way street, we need, ideally, mobile health tools will be those that patients and care teams want to use together and that they can easily be integrated into practice. So it's based on this idea that to be truly patient-centered in supporting chronic disease self-management, we need to also design tools to be provider-friendly. So, and below is my Twitter handle.